Welcome everybody to the second session of the Solid Talk series for 2026. And today we have a special guest from Almaty, Kazakhstan, and this is Sholpan Primbetova. Welcome, and I hand over to my colleague Katarzyna Kowalczyk.
It is my great pleasure to introduce Sholpan, although in Central Asia and beyond, so Sholpan doesn't need introduction. But since we have more people here who might not yet be familiar, as they are, let's say, quite fresh to our Solid project, I will try to introduce Sholpan, but it's quite impossible because Sholpan achievements, I would say, both practitioner and scientific, are so large that I would spend probably like 30 minutes only, listing all the things Sholpan did so far. But let me just mention key of the things that I think are important, especially from the perspective of Solid project. So Sholpan is a Columbia University trained social worker. So this, I think, is you will find very interesting. She's also currently a PhD candidate at the Al Farabi University, but she's adjunct researcher scientist at Columbia University School of Social Work. She was national consultant for United Nations Population Fund and many, many more. So she's been around almost, if not more, 30 years, doing various things. And what I found particularly interesting and important is that Sholpan joins practice and research. So her research now focus on HIV prevention and health equity. So what she does is she's trying to find factors, different factors, that being stigma, violence, economic vulnerability, that shapes HIV risk and access to care among vulnerable populations. But she helped to develop so many guidelines and practical interventions to help people to get help and support, that this is why I'm extremely thrilled to give her the space to talk and discuss a little bit about her work among gender-based violence, particularly among women from vulnerable groups, that being women living with HIV, women using drugs, sex workers, or transgender women. But I'm absolutely sure that with such a great experience, we're gonna touch upon different topics, different projects you've been involved in. And let me just finish with encouraging our audience. Please, it's a absolutely fantastic opportunity to ask Sholpan questions after her presentation. So don't miss it. Don't miss it. It's a unique opportunity. And now, Sholpan, the floor is yours.
Wow, Kasia, I have never been introduced in this way like you. Thank you very much. Thank you to Solid for wonderful project, Solid Talks. It's a wonderful platform for young researchers, for PhD students to exchange and learn from each other. And we are still learning. Every day we have aha moments and like, oh my God, lesson learned. Yeah. So it's pleasure to share my experience. How we are going to do, people will ask questions at the end, yeah?
Exactly like that. So first, if you could present, and then we can also collect questions in the chat. So whoever wants to ask a question can just type it, and we're gonna read it.
Okay. Okay, good evening, good afternoon, dear colleagues. Today I wanted to talk about the social work and public health crisis, which is hiding in plain sight. It's a gender-based violence among the most vulnerable, marginalized, or we call them key affected populations of women in Kazakhstan and beyond Kazakhstan. The problem is similar in the region, Central Asia and in the world. And who are these four groups? It's women who are using drugs, women with HIV infection, sex workers, and transgender women. So this works comes from the study we published last year in the behavioral science, and I hope by the end of my talk you will understand not only how serious this problem is, but also why what we did about it matters and why we were the first one to do it. So let's start with the scale. Globally, 1 in 3 women experience physical or sexual violence, intimate partner violence. Yet today I will use 2 terms, IPV, intimate partner violence, and GBV, gender-based violence. In their lifetime. In Kazakhstan, the official figure is 27%. But here's the problem. That number comes from the National Household Service, which systematically excludes women from our vulnerable groups who are at highest risk in their lives. Then the researchers do study key affected populations, specifically IPV, intimate partner violence prevalence jumps anywhere between 23 and 75%. And this is not the data error. This is actually the data gap. These women are experiencing violence at 2 to 3 times higher than the general population, and most of them are invisible in social statistics, unfortunately. And I like this quote. I don't remember where did I get it. So if the tree falls in the forest and no one is around to hear it, does it make a sound? That's the situation we are in with the intimate partner violence data for these communities, unfortunately. So there is a huge need for better surveillance data on both intimate partner violence and gender-based violence among key affected populations of women. So who are these key affected populations? As I said, there's 2 groups that we are working with. They face stigma. Women who use drugs, they face stigma that prevents them from seeking the help. And substance use and intimate partner violence. These all factors, they actually reinforcing each other in a vicious cycle. Sex workers. 75% of women exchanging sex for money and for drugs in Kazakhstan and experience intimate partner violence in the past 90 days. The third group is the women living with HIV infection. We call them HIV positive women. 52% report lifetime intimate partner violence, and disclosing an HIV diagnosis can itself trigger violence from a partner. It's again like a close circle, yeah? And the most challenging and the most vulnerable group of women here, it's transgender women who face 2.5 times the sexual intimate partner violence risk compared to cisgender women, yeah? And for whom we have virtually no any population data in Kazakhstan. The last point is not a minor footnote. It means we are making policy decisions in complete evidence vacuum. Now, why does this matter beyond the violence itself? Because intimate partner violence, it doesn't exist in isolation, yeah? It is a part what researchers called SAVA. It's substance abuse, violence, and AIDS. This is 3 forces that interact and amplify each other. Women experiencing intimate partner violence are at higher risks for HIV transmission. At the same time, HIV positive status increases vulnerability to violence. Drug use and violence, they feed each other bidirectly. These issues are not 3 separate issues at all. They are problems. They are one interconnected crisis.
So this is this moment.
Yes, aha moment.
Aha moment, thank you.
Yeah. And this is actually good news for the intervention because addressing intimate partner violence has multiple effects. And this is the simple what we achieved. So if we reduce violence, we also reduce HIV risk, overdose risk, PTSD, and substance use, misuse. So you see one intervention and multiple outcomes. So why aren't these women getting help? So there are four structural barriers I try to describe here. We documented in Kazakhstan. So first is data invisibility. You cannot address what you cannot measure. And these vulnerable groups of women, CAPs, key affected populations, are excluded from the numbers. The second one, fragmented services. IPV organizations and CAP organizations, CAP serving organizations, they mostly time operate completely far from each other separately with little or so like at least no cross-sectional referrals for each other. The third one is stigma and discrimination. Women are blamed for the violence they experience. And unfortunately, shelters and crisis centers routinely turn away women with HIV, women who use drugs, women who are transgender, or women who sell sex for money or for drugs or for food. And the fourth one, no community voice. There are very few mechanisms which women from this disadvantaged group can influence the policies and programs that are supposed to protect them. And I wanted to note that Kazakhstan did pass new domestic law. We all know in 2024, we call it Sultanate law. There is a progress, but still the service gaps are very, very real. So this brings me to WINGS. Its WINGS abbreviation stands for Women Initiating New Goals for Safety. It was intervention. It was developed in early 2010s by, here's at the top right, the professor of Columbia University, Louisa Gilbert. She is one of our primary investigators of all studies. And she works for the social intervention group at School of Social Work at Columbia University. And she developed this intervention first for women who use drugs in New York City criminal legal system. The first randomized controlled trials published in 2015 showed it was very effective in reducing intimate partner violence. Then in 2017, the program was adopted for Kyrgyzstan by our colleague, Daniil Nikitin, who is Columbia alumni as well. And from there, it was spread to other countries, India, Ukraine, Georgia, Indonesia, and Caribbean. And the intervention was adopted along the way for women living with HIV, sex workers, transgender women, and women in war zones. And in 2022, we launched WINGS in Kazakhstan, and we gave it Kazakh localized name, Umay, after the ancient Turkish goddess of protection. Today, WINGS operates in more than 10 countries and has reached other 2,600 women all over the world. And our trial in Kazakhstan is now part of this evidence base. WINGS is evidence-based SBIRT model. So SBIRT stands for screening, brief intervention, and referral to treatment and services. And this simple model designed to address intimate partner violence that may be delivered as a digital mHealth online application or by any peer workers in the community, social workers, outreach workers, or any community health workers. And it has here, I wrote it, 7 components. It's very adaptable. Usually, if you adapt for any other project, for Indonesia, I remember they packed more like social support because it was needed for transgender. Yeah. In other countries, they did more safety planning, like Ukraine and Georgia, because they were like preparing to be in the war, like Ukraine now in the war. So right now for them, safety planning is more important. So you actually can play with these components, but it starts with psychoeducation. So raising awareness about different types of violence, including digital abuse, because women, sometimes they don't know that this is the case, she lives in violence. And by reading different cases and answering some questions, she realized the system brings her and identify the risk, what kind of violence. Then it screens for the violence and gives some individual feedback. It uses motivational interviewing, MI, to help women to build their own motivation to change their situation. It supports safety planning. Each woman develops its own safety plan. The system, the application developed in a way that based on the risk, on the situation, of the behavior of women, it develops individual steps tailored to each woman's circumstances. And then it strengthens the social support networks. It helps set personal goals. And finally, it links women to services, IPV, like intimate partner violence, shelters, legal aids, NGOs, community, harm reduction, HIV care, whatever is needed based on the diagnosis. And critically, these links can be delivered by either like trained facilitator or even self-paced digital tool, either on a mobile phone or a computer. So it can be easily used either in the office settings, in some organizations, NGO, or even in the field. So both modalities have been shown to be equally effective. And for the safety, there is a quick exit button, so women can close up instantly if some partner is here or client are here, or she doesn't want everyone to see it. And Wings Pro, this application Wings, the whole can actually be used to collect aggregate data on different types of the IPV or GBV. And then we presented on the national conference, which conducts every year during the 16 days against violence. Yeah, there were so many government stakeholders, and unfortunately, in Kazakhstan, like in other countries in the region, we don't have national data in real time on any types of the violences. We have something from the police, we have separately from 158 hotline, we have a separate data on the crisis centers. Yeah, the government supported, and we have so many like private crisis centers, but we don't have one national data in the real time. And this application actually can provide this data. So our trial, UMAI, we called UMAI Wings in Kazakhstan. It ran from April 2022 until December 2024, and we screened 981 women, enrolled 506, and achieved a 93 retention rate at 6 months follow-up, which is actually remarkable for this hidden population and very hard to reach population. Almaty city was the intervention community, and Almaty Oblast, at the moment we were writing the proposal, it was Almaty Oblast, then it was restructured for Almaty and Jitsu Oblast. These two were our communities were actually waitlist control. So the women in our study were dealing with compound invulnerability. 73% were sex workers. This is how got to our study. 58 used drugs. 31 were living with HIV, and 5%, it's about 24 women, identified themselves as transgender women. But what made our implementation truly different was that we developed the community action and accountability board. Yeah, we included this community coordinated response. In each site, we formed a board that included IPV service providers, law enforcement, NGOs, which serve these key disadvantaged populations, and women who experience violence. This work, they just didn't advise what to do. They actually shaped the whole intervention, identified local barriers, mapped services, built referral programs, and ensured that the model actually fit the community need. Especially with transgender population, we restructured the whole language to fit the transgender population. Yeah, how to use their names, what kind of services, if they need, like what kind of medical special gynecology services they may need. This is the screens from our app, actually. And the next slide, I will show you, it will be in Russian, just a minute. Just, I wanted to show you the screen. I hope it will work here. Do you hear it? So this is the screen, what actually our application looks like. Спасибо, что нашли время для участия в программе онлайн. This is how you create ID code. Then you go through the determination of the risk. Then based on the screening, you identify it yourself and you go through educational components. What kind of violence actually exists? Then based on your risk and the violence, the program develops the security plan for you, based on the questions actually of women, which is provided. And this is the system downloads automatically the individual security plan, which sends to you either WhatsApp or email. This is data, disaggregated data with no any identification information about the participants. And this is the unique, this is the real-time data we collected. So now for the results, and they're really striking. At 6 months follow-up, women in the international community in Almaty city was significantly less to report all 3 types of violence, intimate partner violence, compared to the women in the control group. Psychological intimate partner violence dropped by 23% from 75 in the control group down to 42 in the intervention. The sexual intimate partner violence dropped by 27% from 71 to 44. And the psychological intimate partner violence dropped by 29 from 74 down to just 26. And all this data is statistically significant with p-values below 0.0001. And actually, when we were analyzing data and developing the publication, outcomes paper publication, we tested whether the effects different across these subgroups for subgroups of women, sex workers, women who use drugs, women living with HIV. The answer was no. The intervention worked equally well across all groups. And there was no any differential effect. Wings work for everyone. And this is what evidence-based from each country where Wings is being implemented. And the numbers they're not just about the efficacy. They're about women's experience of the program. Among those who completed the intervention fully, 81 were satisfied, 94 said they would recommend this program to other women, 96 developed their safety plan and they use it and they found it very useful. And across the entire trial, we had no adverse events, no one. So the intervention was safe. And this matters actually enormously for stigmatized populations. The researchers often worry about like inadvertently causing harm, especially all these political situation about these groups of women in Kazakhstan. And what makes this actually models capable is also it's runs on the phone, just simple phones. They download they use the Qualtrics link. That's it. We don't have to download any other special program. It requires no face-to-face meeting. It's available in Russian and we translate it and adapt it for Kazakh population as well. It uses local intimate partner violence scenarios and real cases. And the community infrastructure we built through Community Advisory Accountability Board outlast any individual project. So here I wanted to be direct about what this study represents in the field. This is actually the largest community-based intimate partner violence SBIRT trial with vulnerable groups of women ever conducted. It is the first mHealth IPV intervention for these disadvantaged women in Central Asia. This is the first study in Kazakhstan to include transgender women in the research on intimate partner violence at all. And this is the first to use community coordinated response model for this population in the context. And this is the first effort to build key affected populations inclusive intimate partner violence data system in Kazakhstan. So this is beginning to close the gap, the surveillance gap I was talking in the beginning of my presentation. So why has this been under-researched? You know, because of the criminalization, stigma, discrimination, and exclusion of these women from the national service. What made these actual women invisible to science? Unfortunately, 93% of Kazakhstani citizens hold gender-biased views, and these women are blamed for the violence they suffer. So doing this research actually required trust, community partnership, and many years of relationship building with the communities. And this is exactly what we did. So where do we go from here now? As sustainability and the further vision, what do we do now? We have one research. Is it like fulfill the surveillance gap? Or we have access to the community. We know the problem exists. And we know that a lot of work needs to be done to respond to these issues. So we need longer follow-up periods for further projects. For you, for dear my colleagues, if you're ever going to develop interventions like this, our vision is the follow-up should be longer, at least 20 months and beyond, yeah? Because to know whether these effects are sustained. We need to intentionally oversample transgender women, because our sample was only 24 women, and honestly, it was too small for subgroup analysis, and that has now changed. We need to expand geographically. We went from Almaty to Almaty and Jetysu region, Oblast, but would be nice to go to rural communities, to other cities, to other countries with similar contexts. We need a large-scale randomized control trial to identify what actual components of the model are driving the effects. Yeah, we need policy action, routine intimate partner violence screening in primary healthcare settings. We need shelters which will be friendly to women from marginalized groups and include them. We need enforcement of the new domestic violence law. And we need mixed method, actually. Qualitative interview combining with ecological momentary assessment to understand what is really happening in women's lives. So the disproportionately high rates of intimate partner violence among these women are not just research funding, they are call to action. And this is the invitation for partnership, because I represent here Columbia University Global Health Research Center of Central Asia, working in Kazakhstan and Central Asia for more than like 17 years. I represent Center for Scientific and Practical Initiatives, it's a local NGO, and Kazakh National University by Al-Farabi, Department of Sociology and Social Work. So we are very open for partnership on gender-based violence, on digital violence, on digital governance research, on life course HIV, on cross-border epidemiology, and we bring a lot of expertise and very trained staff here. So Umay Wings showed us that community-based mobile health intervention can actually meaningfully reduce violence for the most marginalized, disadvantaged, and vulnerable group of women in Kazakhstan, in any country. And that can be done safely, acceptably, and at scale. The full paper we published in the Behavioral Science last year, the DOI here on the slide, if you would like to read. And here I am happy to take any questions. Thank you very much for taking part of this presentation.
Thank you very much, Rahmet. Okay, so here we are. This was a wonderful presentation, Sholpan, and I think there were so many interesting points and so many things that we can ask. So I would like to ask our audience to ask question. You can do this by raising your hand. You can also write a question into the chat, whatever you want. And there's a question from Jacqueline Shadimanova. Please go ahead.
Hi everyone. Good to see you, Ulla, Kasia, and everyone. Thank you for the presentation, and it was very interesting to see because Daniel Nikitin actually wrote a chapter on our book, which was actually published by Solid on NGO book, and he shared the how Wings was implemented in Kyrgyzstan, and the insight was very interesting. So my question to you would be first, what kind of barriers did you face during the implementation? And how did you make any changes in order to adapt the Wings in Kazakhstan? And what kind of changes there were? Thank you.
Jurgen, thank you very much for this question. I'm happy that you know personally Daniel and partnered with them, and he was a part of the book. So originally, as I mentioned, the Wings was developed for the women who are using drugs in New York City legal penitentiary system. And then for Kyrgyzstan is what adopted for women using drugs and women living with HIV. We added a component for women sex who sell sex for drugs and for money and for food. And then we, for the first time, Wings was updated to add transgender women. We knew this is the sample will be very small, and we could find only 24 women from 2 sites. But because we have been working with them and we knew that if not us who would build some evidence on gender-based and intimate partner violence, no one unfortunately was doing it in the country. So the adaptation for the sex workers were more or less easier because we had experience working with sex workers from Renaissance study, from Nova study, which we both published. We have several papers on that. But because transgender women, was absolutely new. We work with transgender men in our uni study, working with MSN, men having sex with men. But this was the first time actually we involved transgender women. And we realized, and even us, the researchers, we used their own language. They have been criticized by the community how stupid were our questions, how some questions were unfriendly. Yeah, it was too scientifically dry to ask. So what we did, we delayed a little bit the project implementation, but it took us a lot of time to update the intervention for transgender women. And this was challenging, but it was very interesting. And actually, because the study was funded by the SVRI, Sexual Violence Research Institute in South Africa, I went to South Africa for the SVRI forum in 2020 to actually present our study preliminary results and actually to share the adaptation of the intervention for transgender women.
Nice. Thank you.
Thank you,
Thanks,
Sholpan.
Sholpan.
Very good question.
Thank you. And actually, I also have a question, Sholpan. Thanks for showing us how the device and how the tool is working. Was very informative. I would like to know a little bit more about the advice that you give to the client. So you're mentioning that you develop a security plan. So how does it exactly look like, and how does the project achieve the reduction of violence, of gender-based and intimate partner violence?
I'm sorry, my internet was frozen for a little bit, so I missed the beginning. Would you please repeat?
Thank you for showing the device, and I would like to know about this, the security plan that you develop for the clients. How does it exactly look like? So, what is the security plan, and how did the project Wings Umai, how did it achieve a reduction of intimate partner violence? So, what was exactly the factor that led to the reduction of violence? Thank you.
Yeah, Ola, this is $1 million question. So, because of we collected data at the baseline, the screening baseline, and then only 6 months follow-ups. This period was not enough to see what exactly one of the 7 components work in the reduction. Yeah, to understand what exactly component worked, would be nice to have at least 12 months. But the individual safety plan, so the women would go through the questions. Interesting, one woman, she was even like, oh my God, he's not giving me money. This is called economic violence. This is first time in my life I actually hear. Oh my God, he's slapping me because I thought this is one of the way to give me attention. I didn't know this is the violence. So this is psychic educational component was wonderful. And based on the risk each woman would identify, there are so many questions, the home risks, drug abuse risk, HIV risk, sex work risk, so many risks women would identify. And based on the households threats and these risks they identified, the program was developed to automatically develop the safety plan. And it's like you push the button, generate this safety plan, and they would go automatically on the screen. And there is a button women could download and share it to either her WhatsApp or to send to the research assistant. If she wanted to have it in a paper, we would print it out, or she would send to her email or someday in her cell phone. And this was very useful too. Women would know a thing. It's like anyone, maybe anyone from your neighbors, you would leave the copy of the documents, or you would leave some cash, or you would make a copy of the key, yeah, or maybe you name us address and you leave. Nobody has to know, but maybe you leave this extra pampers for a child, and it was very convenient and it was very we never thought about it. And this safety plan actually stays with them forever. She can use it. Or it was online, it was free. If she wanna go back online and update it based on her real situation.
Thank you.
And we search for different safety plans from different projects, and we adapted not only for Kazakhstan, but exactly for this Almaty city and the oblast around.
Thank you.
Thank you, Allah.
And there's another question from Ingo
Yes,
Ilya
please.
Michels.
First of all, thank you very much for this very wonderful presentation of this project. When I was living in the Kyrgyz Republic 2010, 2011, I was confronted together with my wife on the situation of our friend, one of our friends. She had been violated by her husband, and she came to us and we tried to support her, but she said, no, I don't go to the police. If I go to the police, it will be worse. And at that time, I didn't know about wings in the Kyrgyz Republic. Later on, I knew about it, but at that time, it was not. I think it started a little bit later. On the other hand, as far as I know, in the Kyrgyz Republic, at least there's now a new law which should support the women who are facing violence in their marriages or by men. But I don't know exactly, is this law really existing? Is it working or not? And the same question to you, is there any development to implement such a law in the Kazakhstan?
Thank you for the question. In 2024, we had a very wild case, which was it was a wake-up call for the whole community. The former minister and the prime minister Bishimbayev, he crudely killed his wife, Saltanat, and the trial was recorded online, and not only citizens of Kazakhstan, like the whole world, I know my friends around the world, they have been watching it. And he lost the case. And after this, government decided to respond, to show the country that, oh, we hear you. We understand this is the issue. We need to change the law. The law on domestic violence was changed. But the lawyers say that it still not fully reflect the international conventions on the women's rights. We still, at the police, we have the departments on domestic violence. It's good that now they change and more female police women workers work there, because it used to be that the man policeman, and then women would come with the case against her husband. We had cases, then the policeman say, oh, come on, this is the between you and husband. It's a yacht in Kazakh language. It's a shame on you. How you can like disclose it to the whole world? It's your fault, yeah. So now we have more female policemen, and actually the policeman protocol is working okay here. They immediately contact the government-run crisis centers in Kazakhstan. We have one shelter crisis center in the Oblast city, but it's not, of course, enough, yeah? And as soon as you enroll there, you and your, like how many children you have, the whole family is accepted there in a secure place. It's provided 8 services, yeah, like medical, legal support, kids go to school, like she got psychological support, like if she wants to work there, she can work, and they can actually stay until 6 months. But as I mentioned, these shelters unfortunately exclude women who are using drugs or who are doing sex, work, or transgender women, because not all transgender women, they change biologically. At the moment, they are being raped. So there are still a lot of issues how we protect women from the vulnerable groups in comparison with women from cisgender population.
Thank you.
If I cover it.
There's another
Correct.
question from Dalida. Dalida, would you like me to read your question, or would you like to ask yourself? It is in the chat. Maybe it's so that she cannot speak at this moment, so I'm going to read the question. Given your research finding, Sholpan, what priority changes in service delivery protocols within healthcare facilities or NGOs do you consider essential for Kazakhstan to make services more sensitive to the needs of women living with HIV and women who use drugs? Thank you.
Thank you very much. So priority changes and service delivery protocols. Okay, so for women who use drugs and women living with HIV. So unfortunately, especially women who use drugs and women living with HIV, they face a lot of stigma. So on the first step, we have to, and this is the stigma might be different. It's like community, self-stigma, but on this level, because we speak about the healthcare, yeah. So unfortunately, they're facing severe provider level stigma, yeah. And for women, if women living with HIV, they have their special aid centers or HIV clinic in each city and each oblast. Women who are using drugs, they can go to narcology dispensers, but we have OAT, PTAO, it's opioid agonist therapy with methadone. Yeah, methadone is evidence-based treatment not only for drug use disorders but HIV prevention, but still the government, the police, the private narcology, they're against methadone protocols in the country. Another one, it's like structural discrimination in services. So if women with HIV status or using drugs, they wanna to use she's thinking about the pregnancy or abortion or delivery method. She is facing these barriers. Then they face this breach of confidentiality, sometimes even like the forced disclosure of their status. And as I mentioned it in the presentation, it's intersecting vulnerability. Yeah, it's a gender, if it's high level of violence, then drugs, and then HIV. It's really if women using HIV, women using drugs, and sometimes she is HIV positive, yeah, because of this reverse. She is the facing all this strangulation, the partner abuse, the police, the structural violence. Yeah, and unfortunately, in many cases, what we have learned from these groups of women, they face fragmented, non-integrated services. It's like for HIV, we have to go to the AIDS clinic. For drug treatment, we have to go to the drug for narcology, for gender-based violence, for mental health, for social services. They are all siloed. Yeah, they are all like spread out in the city. Rather than, you know, in European countries, they call it one window services. Yeah. And yeah, we need to actually change the priority in the service delivery protocols. So would be nice to have the services which are low thresholds and really like women-centered. So because we still have requirements in many protocols, services like HIV status, this is the obstacle, abstinence, Propiska residence. Yeah, if they don't have residence, Propiska, she is not attached to the primary health care, and meaning that she is not eligible for the government-run insurance. And in many cases, the protocol is written in the way that they force to disclose their status mandatory in many cases. And would be great to integrate HIV, gender-based violence, mental health, and substance use services. Yeah, maybe like to make the shift in the country from siloed services to integrated care pathway, based on our example. Yeah. And what we are doing, we include mandatory anti-stigma training for providers, healthcare providers, providers that work at the AIDS centers or narcology dispensaries or shelters, and bring more kind of like community-led services delivery. Yeah, I think and the issue of confidentiality should be critical in the protocol. Yeah. I guess.
Thank you.
Sholpan, I have a question to you. First of all, thank you so much for this comprehensive presentation. I asked on purpose, Sholpan, to discuss a little bit more about the WINGS project, as this is something I came across when I started to work in the region. And I've read a couple of papers, but I really never get into the details of it. So now I'm absolutely under huge influence of how complex this project is and how many different also parties you involved in to reach out to the hard to reach out group of women. So this is also a beautiful example of when we think about finding solutions to the problems of HIV, of treatment, we have to go beyond just solely treatment, right? There are other factors, other components that are highly crucial and important to tackle. So a question I have to you is a question that we started a little bit to discuss at the beginning of our meeting before everyone was here. And this is about translating research findings into policy or programmatic policy change. Like, we know as a researchers that it would be great if we were listened, if our research findings were listened by the policymakers, but it's not that easy. And you, since you are right now on the both sides of the barricades as a researcher and as a practitioner, maybe you could comment on that. How does this research findings translate into policy and shaping policy and response to HIV and gender-based violence in Kazakhstan?
Kasia, thank you very much for the question. Yeah, you're right. The research in Kazakhstan and the region contributed significantly to the development of the both harm reduction and HIV prevention and GBV programs. Yeah, both needle and syringe and OAT, opioid agonist therapy. Yeah, and it has been done with the funding from the global fund, from the local government. It's been a lot to expand HIV testing program. Now we have pre-exposure prophylaxis. Yeah, we started to have it only for MSM, men having sex with men. Then we expanded to all key populations, and now it's getting available even for the general population. Yeah, we have needle and syringes programs in the 8 centers and some polyclinics. Yeah, a lot has been done. However, this is the important point to translate evidence into the policy. It's really non-stop and ongoing process. Yeah, particularly then it involves politically sensitive issues like drug abuse, drug policy, sex work, or structural stigma. And you might know that last year in September, unfortunately, the government of Kazakhstan, they criminalized sex work and LGBT community being under the pressure. And it's been really, we think as a researcher, it's a huge step backward from what we have done with the research in the country. Yeah, and there is still a huge gap between the research and policy in opioid agonist therapy and criminalization and the policy and practices, then pushing people away from accessing actually the prevention services. And because this is the sex work remains criminalized or heavily policed, we don't know why. Is it like influence of Russia? Is it like the what opposition is doing? So this is still creates a lot of barriers, and it's very sad and a shame that we bring so much know-how to the country. We build the interventions. So much work has been done by other researchers and the NGO leaders, communities in the country to build evidence to actually talk to the government, to the stakeholders, and to speak about the cost-benefit analysis. Yeah, it's only it's a very pity, unfortunately, but what to do? We continue to collaborate with researchers, with the community organizations, with policymakers, just to ensure that this is the scientific evidence, and one day it will bring to the sustained programmatic and policy change. So we try to bring, we spoke about in the beginning, that we try to, in the beginning of our work, we're like, this is the best example from Latin America. This is what work in the States. Or this is wonderful evidence-based from European countries. And our government always say, oh, come on, this might not for Kazakhstan. If you would bring us Kazakh's example, it might work. Okay, we built for so many years, we extrapolate this to knowledge, but still there is resistance. Some ministries are more friendly, some because of this political insensitivity there still. So it's a wonderful question. We would love to to know the answer by our own. But thank you.
Ingo, did you raise your hand as well, or is it the previously raised hand? Mm.
Now, just want to add small information about the situation in the Kyrgyz Republic. As far as I know, and when I have been working, there are some NGOs working in this field. For example, the Asteria working with women drug using, and
Yes, I
I
heard about
just
that.
realized that I just sent it to you that they're also part of the wing system in
Glory.
Kyrgyz Republic.
I see the link. Yeah. So you have been living in Kyrgyzstan, Kyrgyz Republic?
Yeah, 2010 to 2013. So in
Oh,
Bishkek so
wonderful.
far.
In Bishkek. Oh, nice. Wonderful.
Mhm.
Yeah, the
So,
problems are
Sholpan, yeah, one more question, and this is to you as a researcher, as a PhD student. Can you tell us more about the topic of your research and where are you with the whole process? I know might be a very indiscreet question that PhD students don't like to be asked, but I think it's quite interesting also for our audience.
This was actually in my research thesis question. So the GBV among women from marginalized populations, because there have been a lot of work done among PhD students on general gender-based violence among the general population, but I'm the first one in the country who is bringing the topic of GBV among marginalized group. And I remember then it was a defense of my topic. There were deans from different schools and one of the head of the department of religious studies. As soon as he heard like transgender sex workers, we don't have it in Kazakhstan. Why you are working? I was like, exactly. This is the gap between you and the reality. So this is my research topic and my PhD thesis. I'm on the second year, so still have one more year to finish my one more paper and write the thesis.
No, this is fantastic, and I think it's not only Kazakhstan, but we all are waiting for your thesis, and hopefully we will also be able to read it. Are there any more questions you would like to? I have seen many thank you in the chat, but maybe there is still some questions that someone would like to ask. If no, then again, I'm gonna repeat that you will have opportunity to meet Sholpan in person during during Almaty Social Work Conference, and we will exactly heart. We will not miss this chance, Sholpan. So I think we can conclude and finalize. Thank you so much, and for sure we're gonna stay in touch.
Yes, definitely. And see you in Almaty in May. And thank you very much. And thank you, Ayagos, for organizing it.
Yeah.
Thank
Good
you.
luck to everyone. Have a wonderful evening.
Thank you.
Bye-bye.
Thank you,
Thank you,
Goodbye.
everybody.
Thank you.
Thank you.